We know that intimate partner violence and childhood sexual abuse are two of the most prevalent forms of violence against women and children across the globe. So almost 1 in 3 partnered women have been exposed to some form of intimate partner violence in their lifetime around the world. And almost 20% of girls and almost 10% of boys have experienced some form of childhood sexual abuse across the globe. That's what our current estimates are. So these issues affect millions, if not billions of people, and they are really damaging not only to the individual, but to the family, to communities. And of course, here we're focused on the health impacts, but they can have really detrimental economic impacts as well. So when we think about the health impacts, we're thinking not only about the immediate health impacts of an experience like this, like injuries, but also the impacts that follow an individual over their life course in the medium and longer term. And those sorts of medium and longer term impacts were really the focus of this work, where we're trying to understand, once someone has been exposed to an experience like this, what happens over their life course, and what does that mean not only for them, but also for generations to come. The main purpose of this research was to assess all of the available literature reporting on the health impacts of 2 forms of violence against women and children, and those were intimate partner violence and childhood sexual abuse. So those are 2 very prevalent forms of violence and affect millions of women and children across the globe. So we wanted to take a look at everything that's been reported and published and really seek to understand what exactly the health consequences of being exposed to these forms of violence is and how strong those associations are. So we did this, and we found, not unsurprisingly, that there are wide-ranging mental and physical health impacts associated with both forms of violence. And I think that finding really underscores the need to invest in violence prevention, but also in ensuring access to care and support for survivors. I think the mental health impacts have been highlighted in the past and are sort of maybe the health outcomes that folks think of right off when they think about being exposed to violence. In this paper, we did find those mental health impacts. So for instance, for intimate partner violence, we found a fairly strong association with major depressive disorder, with our results suggesting a 63% increased risk for folks who have been exposed to intimate partner violence. But those mental health outcomes range from not only major depressive disorder, but range to things like anxiety disorder, schizophrenia for childhood sexual abuse. We found that connection there. But I think something that is even equally important to highlight from our findings is that we also found physical health outcomes, which maybe haven't been reported as strongly in the past. So for childhood sexual abuse, we found an association with health outcomes like diabetes mellitus and also asthma. So we're seeing that these health impacts are not just concentrated to the mental health, but also span into physical health and sort of affect people in many different ways. Another key takeaway from our analysis and this piece of research actually is the sort of lack of available data that we also found for intimate partner violence and childhood sexual abuse and their health impacts. So while we showed sort of wide-ranging and really massive health impacts, we think that this understanding is still really limited because we didn't find as much data as we would have liked or hoped to have found. So to put this into context, our most studied outcome that we found in association with intimate partner violence, we found 12 studies that met our inclusion criteria. And those criteria really just related to the study design and the way that they measured things that enables us to be able to use it within this work. So like I said, we found only 12 for intimate partner violence in the most studied outcome. And for childhood sexual abuse, we found 26 studies for the most studied outcome. If we compare that to other risk factors like smoking or high blood pressure, those risk factors have over 75 studies going into their analyses. So I think that really shows that there's still some pretty large data gaps in this area. And to the extent that we think the data availability shows the priority level of the risk factors, I think that shows that intimate partner violence, childhood sexual abuse, and violence against women and children at large have not been prioritized as highly as maybe some other risk factors. And so that does limit what we're able to analyze and say about the true, range and extent of the health impacts associated with these forms of violence. Intimate partner violence and childhood sexual abuse are two of the most prevalent forms of violence against women and children that we know from having measured across the world, unfortunately. So in this paper, we focused on those two forms of violence and focused on trying to find the health impacts associated with them. They also are the two forms of violence that are studied in the Global Burden of Disease study. So this is a big epidemiological study which looks at the health burdens of many different risk factors beyond violence-related ones. But intimate partner violence and childhood sexual abuse are included in this study. So part of the goals of this work were to improve how we understand the health impacts of those two risk factors within the context of this larger global burden of diseases study. And then in the future, we hope to sort of expand beyond those two types of exposures and to other forms of violence, which might not fit into those definitions, but are equally important to look at and understand what the health impacts are. And while they might seem separate, intimate partner violence and childhood sexual abuse are very interconnected issues. They have similar risk factors. As we saw in the analysis, they have similar health outcomes associated with them, and they often occur in the same families and kind of reverberate across generations. The star rating system was created really as a way to make the findings from our analyses as sort of interpretable and actionable as possible. So the star rating captures sort of the strength of the association that we found. And it also can reflect the level of consistency between the studies that went into that particular analysis. So the possible ratings range from 0 to 5 stars, with 5 stars sort of indicating the strongest evidence of association and 0 stars indicating that we didn't find evidence to support an association. So for some of the risk outcome pairs that we present in our paper, we did find 1-star associations, which could be interpreted as weak evidence of an association, and also can be interpreted as an evaluation of the evidence that might change should we get more data and more studies in the future. So I think with, for example, intimate partner violence and anxiety disorders, we found 5 studies to draw upon for that analysis. That's a relatively low number of studies. So there's definitely, a call for more data in that regard. And the studies that we analyzed were not all that consistent with each other. And so that sort of leads us to a lower association, the 1-star association, where we think there's weak evidence of an association, but that assessment might change in the future if we can get some more studies to draw upon. The associations and methodology of our analyses are not to say with any certainty of any individual who might have experienced violence will or will not go on to develop these health outcomes. So having a 1-star association for intimate partner violence and anxiety does not mean that that is with certainty a not important health outcome or should not be addressed. And for anybody who has experienced intimate partner violence and might feel that these associations are reductive or not reflecting their experiences, that is not the aim of our analysis and not the aim of the STAR rating system at all. This is to say, this is the evidence that we found. This is what we were able to synthesize from the data. And throughout our paper, we really do make the call for more high quality data on these topics, especially since they haven't been studied to the extent that other risk factors for health have, so that we can understand the true extent of the health impacts and how strong each association is. I think that the call for more data can be answered by funders. There needs to be investment in high quality data collection around these areas. And what I mean by high quality data, particularly for the purposes of an analysis like this, is data that really follows individuals over time. We're looking to see how experiences of violence impact folks over the courses of their lives. And that requires sort of following people over time at multiple different time points. And of course, that requires a larger investment, but that also yields sort of the most high quality epidemiological evidence. There are many challenges associated with these topics. They're really heavily stigmatized almost everywhere, and certainly in some areas more than others. So that can make it really difficult to accurately measure who is experiencing violence. There's all sorts of concerns about safety, about disclosing an experience of violence, and safety within one's community, what the repercussions of disclosure could have on them and their families and their larger communities. So it is a very challenging area to try to measure accurately. But that's not to say that other risk factors don't have similar challenges, and I don't think is a reason to not measure these areas at all. But of course, we just need to take into account how to do so in a way that really prioritizes the well-being and the safety of the respondents and folks who might be experiencing violence.